This conference will now be recorded.
Okay, Tracy, go ahead. Tracy, you might need to unmute your line again. Star 2.
Good afternoon, everyone. This is Tracy Morton, and thank you for joining us today for the TASC 90 webinar. We appreciate you adjusting your schedule to join us for the call today versus kind of the February normal date. So thanks so much for being here. Today we have a couple of different updates, both from TASC and as normal from the Federal Office of Rural Health Policy about programs as well as critical access hospital regulatory changes. We'll then have an update on the student loan repayment program and a flex monitoring team update. And then our topic today will be presented by Tom Morris, who's the Associate Administrator for Rural Health Policy at the Office of Rural Health Policy within HRSA. And he's going to be talking to us about setting a context for emerging oversight and analysis of critical access hospitals. Kind of a current update about what's happening within the national and federal system as our healthcare system changes, and some clarification about some of the administrative and governing bodies that are involved with that. And then hopefully we'll have some time for questions and conclude today at 3:30 Central Time. So I'll begin here quickly with just an update from TASC. We certainly have a lot going on this quarter. And starting that, in the next few weeks on February 6th, we have an in-person meeting of the National Rural HIT, or Health Information Technology Coalition. And they'll be meeting in conjunction with the National Rural Health Association's Rural Health Policy Institute. The meeting will include national and federal updates, an update from the Office of the National Coordinator for Health Information Technology, a discussion of current issues from the field, a status update about rural broadband, which is an issue we've been talking about for quite some time, an update on the current rural telemedicine issues and accomplishments, and an update on the Paramedic Information Privacy and Security, as well as Assurance Alliance. So if you're interested in further information about that coalition meeting, please contact Kate Stenyum. The Center and ORHP will be hosting a small group meeting in late March to discuss rural population health. And that summit meeting will discuss current challenges and future thinking for moving rural health into the new healthcare arena of value-based care, and what that really means for shifting a focus to population health in our rural areas. So look for supporting materials and further updates to come out of that summit meeting in the spring. We do have a Flex program workshop here in Duluth, April 7th through the 9th. That workshop's not only for a great training for those that are brand new to the Flex program, and I'd say actually critical for those that are brand new to the program, but also very useful for those that have been with the program for a bit but are interested in an update about kind of the latest happenings and changes that have occurred within the program. It's a very small workshop. We try to keep it actually at about 12 participants, so if you're interested in attending, or you want further information, please contact Nicole Clement to hold your spot or get some more info. We're working on a couple manuals here at TASC as well. The updated version of the Flex Coordinator Manual, which is mailed to all the Flex coordinators, as well as available online, will be out by the first week of March. And we're also creating a federal grant writing manual that should be available also the first week of March. And that should be really valuable for writing any federal grant, including the Flex grant, so look for that to come soon. We're working with the Federal Office of Rural Health Policy to plan a webinar series about Flex-related education in lieu of not having that face-to-face meeting of the for the National Flex Conference this summer. And that webinar series, we don't have the dates completely scheduled for that, but that'll happen in May or June, so more info to come on that. And lastly, thank you to all those that completed your Flex state profile. Those have been uploaded onto the TASC website. So take a chance and look at the new content on there. If you have any corrections, certainly let us know. And also an electronic summary of all those profiles will be put together and distributed in February as well. Does anybody have any questions for me or any of the TASC staff? Okay, well with that then, I'll turn things over to Commander David Dietz and Aaron Fischbach, who will be providing the update from the Federal Office of Rural Health Policy and an update on critical access hospital regulatory changes.
Thanks a lot, Tracy. This is David Dietz, and I just have a couple of announcements here. For those of you who have not heard this before, critical access hospital closure monitoring, please let your project officer know as soon as possible of any rumblings or rumors of possible closings of hospitals within your state, as we'd like the opportunity to discuss with you specific TA that could possibly make an impact regarding a potential closing. This also applies to all SHIP-eligible hospitals, so it's not just critical access hospitals here, but all SHIP-eligible hospitals. The NRHA Policy Institute, the Institute meets, actually is held in February from the 4th to the 6th. The morning of Thursday, February 6th, the Office of Rural Health Policy will have a 2-hour meeting from 9 to 11, by which we'll give updates on SOAR, SHIP, and the FLEX program. So hopefully, I know there are other meetings during that time frame, but hopefully many of you will be able to stop by and peek in and ask some questions. We'll have a more detailed schedule out to everyone in the imminent future. PIMS. PIMS is becoming closer to a reality, I promise you. For NCAA basketball tournament fans out there, and I know there's some on the call, think early to mid-March it'll be up, live, and ready. Mike and I have seen the site several occasions, so we assure you that it is a vast improvement over the previous iteration. Also, I know a couple of you have responded to Mike and I in terms of being interested in beta testing the site in early February, so anyone else who has not yet responded to Mike or I, shoot me an email if you want to participate in a 2-hour or so beta test of the site and you get a little sneak preview. Next, Flex FFRs and carryovers. Please have your FFRs in by January 30th and your carryover requests in by February 28th. These are hard deadlines. These are not negotiable deadlines, so please be responsive here. If you can, and you do have carryovers, get the carryover request in as soon as possible, because there is an internal process here whereby the project officer and I look over expenditures over a certain threshold for approval. The SOAR NCC application is due February 14th, so I imagine most of you have already begun to work on that. Thanks to everyone who participated in the Flex work group so far. I've talked to many folks offline, and the response has been great. There have been a lot of good suggestions so far, some good conversation, and a lot of the content thus far we'll be able to wrap in the competitive grant application. So keep participating, keep voicing your opinions in a respectful manner. Lastly, to those of you who are attending the Policy Institute in February, please remember that grant dollars can't be used on the day of a Hill visit. If many of you or some of you are planning to make a visit to Capitol Hill, you cannot spend grant dollars on that day, whether it be travel, hotel, meal, etc. Again, we won't be able to effectively police this, but in case we are, our files are looked at or examined closely, please do not do this. And Tracy, that is all I have at this point.
Great. Thank you so much, Dave. Aaron, are you on the line?
I am.
Great.
Welcome, everyone. And I figured I would give a brief regulatory update. So despite there being 10 slides, don't panic. If you move on to the next slide for me, or, yeah. Oh, we can do it? Okay. So the first thing is just a bit of an update on the 2 midnights policy. Most of you have probably heard about that by now, that CMS instituted, or they clarified, according to them, a policy that to admit someone as an inpatient to a hospital or critical access hospital, they have to expect that they'll be there for 2 midnights. They're in a process where they're reviewing admissions right now through March 31st, and CAS aren't part of that. Other rural PPS hospitals are. But the main point is that bottom bullet is that because critical access hospitals receive cost-based reimbursement for inpatient and outpatient, there is no additional cost to Medicare for getting this wrong. So while they expect critical access hospitals to comply with the policy, they probably won't be, they pretty much won't be a target for the RACs for audits, because there's no effect and there's nothing for the RACs to earn commission on. Next one, please. The CA 96-hour payment rule, you may very well have already heard about this as well. we're all aware of the condition of participation, that is the average length of stay must not exceed 96 hours. That's not what this is about. This is in doing an update on the Two-Midnight policy. CMS reprinted something and amended its, and just changed the policy, didn't change the policy, added something to that section of the rule, but the fact that it was in the rule surprised some people. They weren't aware of this, is that since 1997, there's actually a payment condition that a physician has to certify every admission that the patient will be discharged or transferred within 96 hours. This is something we're actually going to be meeting with CMS a little later this week, and we hope to get some clarification about whether and how they actually plan to do any enforcement of this. It's probably going to be tough, but it's an issue. So next one. The next slide is just some resources on those two issues that you can go to for more information. Next slide, please. On late November, so this was after our last call, CMS issued a couple of the standard patient rules, the physician fee schedule, and the OPPS. So I wanted to just very quickly go over those here as well. So some of these may be very familiar already. Some of the payment increases include increased payments to mental health service providers. So as they adjusted the net of all payment adjustments in the new system, mental health providers were some of the best, received some of the biggest increases, while some of the others were neutral or some small decreases. Two policies that went into effect that are rural relevant. One is they did implement the cap on critical access hospitals for outpatient therapy services. So other entities have been subject to these limits before. Now critical access hospitals will be. Note that as long as Congress continues it, there is an exceptions process, so it doesn't have many teeth right now. So watch for that in case that goes by the wayside. The other thing is that they are calculating the value of this therapy services provided based on the fee schedule. So the hospital will do its cost-based reimbursement and run charges, but they'll have to run a side calculation on when a beneficiary reaches the cap based on the fee schedule. The second thing is that CMS opted to use the ORHP definition of rural to define rural HIPSAs for Medicare telehealth originating site eligibility. So we worked here in HRSA to develop a web page where anyone could go and just check. So it takes into account both the old definition of if you're a non-metro county, it'll check that, but it'll also check if you're rural and in a HIPSA. So you can just enter an address and determine whether your site is eligible to be an originating site. Next page, please. A little more on the physician fee schedule. Note that any incident to physician services has to be compliant with state law, including scope of practice. There have been some issues with that CMS wanted to clarify. Two additional initiatives that they're teeing up for 2015 are that there will be a chronic care management code that is not a face-to-face visit. It's the associated non-face-to-face chronic care management services that might be provided. They're going to develop a code for that, and so they'll be able to charge for those services. They're figuring out just who will be able to and what the requirements will be. The other thing is they're taking the next step on implementing the value-based modifier, and they're going to apply it to groups of 100 or more eligible providers. And there's a link to the physician fee schedule final rule if you haven't seen that yet. Next slide, please. The outpatient prospective payment system had a couple of rural relevant provisions as well. One is that the outpatient therapeutic services are now subject to direct supervision by a physician or other authorized non-physician practitioner. They had implemented this policy, but then they had stayed it and had an enforcement waiver, and they have ended that, and now this is in place. So there's a process to request CMS consider some some of the codes, if you have justification for a code, to still be on general supervision rather than direct, but the standard is direct now. The second bullet there is they are collapsing of the 5 outpatient clinic codes into a single code, and there will not be a new and an existing patient code, so they're trying to simplify the outpatient billing. The third one is Medicare EHR incentive program. Because of the way that Method 2 CAs submit their charges, CMS wasn't able to identify the physician practitioner on a claim, and therefore physicians who assign their benefits under Method 2 weren't able to be paid for an EHR incentive payment. They fixed that. They're going to miss out on 1 year of eligibility, so they won't be eligible for the full $44,000, but they will be able to get the other year's worth. And then they did remove a couple of measures on the outpatient quality reporting program, and they added 4 new ones, and they also provided a sort of an exemption for those with fewer than 20 procedures, so a small volume, basically. They're trying to address the small volume issue. And there's a link to the OPPS final rule. Next slide, please. Also wanted to let you know that they issued final rules. 3 agencies together issued final rules in early November on mental health parity issues. I'm not going to go into all the details here, but basically they're moving toward providing parity between mental health and substance abuse services and medical and surgical services. And so you can check out the fact sheet there. Next slide, please. And the last one is that on December 27th, CMS and the HHS Inspector General issued some final rules that are extending their current safe harbors and exemptions to the Stark Law for hospitals that donate EHR systems and some eligible related training to physicians. So it had been set to expire at the end of 2013. They went ahead and extended it to 2021. And one of the objectives is to try and get also that they might work together and get these into mental health and substance abuse providers' offices and even long-term care. But there are links to the 2 final rules. They're very similar. And that's it. And we'll take some questions.
Caleb, please press star 2 on your telephone keypad to unmute your line and ask your questions.
Hi, this is Caleb from Colorado. I had a question about how a hospital or provider is to certify that general or the other type of observation is being done. And I'm sure the fiscal intermediary, I can ask them how they're going to review whether or not that general supervision was certified, but I wasn't sure if there's been any clarification on how a hospital ought to be certifying that general supervision is being done per case.
I think for supervision there isn't a certification requirement. I'll have to confirm that, but I'm pretty sure there isn't actual certification requirement for the direct supervision. They just have to be in the facility and readily accessible.
How would I attest that, though? How would it get denied? So I guess my question would be, how would it get denied, so I can make sure to work backwards from that to how to verify that it can't be denied because my doctor was in the room.
I think that's the challenge that a RAC will have, is basically to document services that require direct supervision and to, honestly, I'm not sure how they'll do that. It'll have to be through an audit and they come back in and look at timesheets or something.
Cool. Thank you.
Yep.
This is Pat Scow. I was just going to add that we've been talking about that in Illinois, and what we're looking at doing with our hospitals is most all of them have schedule in your hospitals. They generally have schedules for ED coverage because CMS is allowing physicians that are covering in the ED or mid-levels or whatever. And so they're going to keep their schedules for ED coverage or in-house. If you have a hospitalist or other thing, they're just going to keep the physician schedules. So, or else you can use, build your own form and track who is available for that outpatient procedure. So I don't know if that helps.
Thanks, Pat.
Yeah,
Any other questions for Dave or for me?
Yeah, this is Kenny in South Dakota, and I had a question regarding that 96-hour rule.
Okay.
After that, the open door session, I did a little research on that, and one of the things I found was when they were switching over from the rural primary care hospital to the critical access hospital, the government county office created a document where one of their recommendations was the enforcement of that rule, even though it's been around. So my question would be, is just enforcement now being developed, even though the rule's been around?
Our understanding from CMS is they didn't realize this was an issue with some hospitals until the comments were made in the rulemaking process. So they just added a provision referring back to the 2 midnights policy to this payment policy, and that's when people realized it in the rule that it required this other certification. So I don't think CMS I'm not sure if they're going to implement any additional kind of enforcement mechanism, but I mentioned we'll be meeting with them a little later this week, and we're going to ask them that question specifically. So I would guess they're probably not going to invest a lot of time into enforcement of that, but we'll know more later this week, and we'll let folks know.
Okay.
We'll find a vehicle.
Yeah, because it sounds like it's always been there, but they just really didn't have a way to enforce it. So.
Right, and there are some who are looking at trying to do away with it, so we'll see what happens.
Yeah, this is Kevin Dries, and also about the 96-hour rule. Would you clarify what the penalty is for if a hospital is found not in compliant?
I would imagine forfeiture of the payment for the services provided.
The entire payment, or only?
Just my guess. I mean, there's possible if they were found to have repeatedly violated, there are certainly some other enforcement opportunities. They could come after the hospital for violation. They could. I mean, if it was serious enough and repetitive, they might get to the point where they did something with their certification as well. But I would imagine if they just identified a specific case where that happened, it would probably be payment of that stay. I would imagine it could be the entire stay. I don't know whether they would prorate it based on extra days or how they might do it. We did make the point to them that it is a narrow window that you have to have 2 midnights. To admit someone, you have to expect they're going to be in for 2 midnights and that they're going to be out the door one way or another in 96 hours. So they realize that is a narrow window, which is why I don't think there's going to be heavy enforcement of it. But we'll confirm that.
Any other questions for Aaron or Dave? Okay. Well, thank you so much, gentlemen.
Thank you.
I'd like to welcome Captain Janine Willis-Marsh, who is the Director for the Division of the National Health Service Corps at the Bureau of Clinician Recruitment and Services at HRSA, who is joining us today to provide an overview of the state loan repayment program. Thank you so much for joining us. We really appreciate you taking the time to be here.
Okay, thank you so much. Good afternoon, everyone. I just want to give a quick overview of this LERT program and make sure that I leave some time for questions. We currently have 32 grantees, and we are going to open up a competition this February. So the timing of this presentation is very timely. So SLRP is a program that has been in existence over 20 years. and it's administered by HRSA. It provides a dollar-to-dollar match to states who have an existing loan repayment program to help them make awards to providers within their state and that are committed to practicing in a health professional shortage area. The matching funds have to come from a non-federal source. And when we as the National Health Service Corps look at our overall field strength and report to the department and to the White House, we actually include the number of awards that are made under this SLRP program in our overall field strength because we do consider it to be a strategy to increase access to care. Next slide, please. And next slide. I'm sorry. Okay. So just a little bit about how the program works. So the states manage their own application and award process, but the providers have to practice at an approved site, and it has to be a nonprofit site that offers primary care services and has a sliding fee scale. It could be either a National Health Service Corps site or site that has been approved by the grantee. As I mentioned, the site has to be located in a HPSA, and according to statute, all initial contracts, again, much like the National Health Service Corps, must be awarded for a minimum of 2 years. One of the good things about the program is our grantees are able to provide continuation contracts. So if they have a provider that still wants to participate in SLRP beyond the 2-year commitment, the grantees are able to ask for matching funds and award those contracts. The initial award amount for over that 2 years can't exceed $100,000. So the next slide, please. Oh, stay on disciplines, sorry. So the eligible disciplines, I'm not going to read through them all, but I just wanted to call out the last 2 disciplines, the registered nurse and pharmacist. These 2 disciplines were added as an eligible discipline to the SLRP program approximately 2 years ago. So we have some states that have been able to capitalize on this and have included practitioners under these disciplines in their program. Some are actually working on it and working on their guidelines. Others, sometimes in their statute, it states that they are not able to add any additional disciplines other than what's in statute. Next slide, please. So again, here are eligible practice sites. As you can see, CAUSE are an eligible site. And again, I want to call out the last 2, the state mental health facilities and long-term care facilities. When we added in the pharmacists and registered nurses as an eligible discipline, we expanded the eligible practice sites to include state mental health facilities and long-term care facilities. Why this is important is because for the National Health Service Corps, these are not eligible practice sites, with the exception of the CAUSE. Next slide, please. So I mentioned that we are going to be hosting a new competition. We expect for the FOA to be announced and open in February. So in terms of who's eligible to participate, all U.S. states and territories, and like I said, we have 32 grantees, and if you look on the slide that's before you, those are our eligible grantees. Our grantees that are currently participating, excuse me. So next slide. Our average award amount is around $319,000. Unlike other grant programs, we don't have a cap that we state in the FOA for the awards. We encourage states to propose a budget amount that they will be able to definitely utilize during the budget period to make awards. Some of our grantees only request $150,000. We have some states that request $1 million. So it really runs the gamut. The average award amount to a provider is around $40,000. We don't dictate the award amounts to providers other than the award can exceed $100,000 during the initial 2 years. Some states have a scale where their physicians, the award amount may be more than their mid-levels. It really is optional. The states can utilize the funds to the best of their abilities. Some states actually increase the award amounts for those providers that agree to practice in hard-to-fill sites or in areas that have extremely high needs or a high HPSA score. So just a little bit about process. Every state runs their process a little bit differently. Most of our grantees host multiple application cycles and could just continue making awards until all of their funds are expended. Some of our grantees pay the award amounts directly to the participant. Some, I think we have 1 or 2 that pay actually to the lender, which is a huge level of effort, but that's what they want to do. And again, some of our grantees disperse the award amounts in one lump sum, and some disperse them in increments. Okay, so the program, under our program guidelines in the FOA, we do require our grantees to monitor not only the participants to make sure that they are fulfilling their contract with the state, but also to monitor sites to make sure that they're meeting the program guidelines and policies. Next slide. So I just want to, I've already touched a little bit about program flexibilities. And I said the states have the ability to determine the award amounts up to $100,000. A state can determine what disciplines they want to support, although I provided you with a list of disciplines that are eligible for the SLRP program. States have the ability to determine if they want to support all 1, 2, 5. It's flexible. Much like the National Health Service Corps awards, our SLRP grantees are able to offer full and part-time options as well. And so we encourage states to tailor their program to meet their needs. Some of our grantees may use the SLRP funds, for example, for oral health initiative. Again, some may use the funds to target high HPSA areas and getting those folks into practice. Next slide, please. So I got a little bit ahead of myself. Just to give you a little bit more, a few examples, for example, the state of Maryland uses the SLRP funds to support their health enterprise zone. There are some states who really pushed us to make state mental health facilities an eligible practice site. So some use the funds specifically to fund those providers at those facilities. So again, the states have a lot of flexibility in determining how they want to use those funds. Next slide, please. So let me just say, one of the challenges with this SLRP program is the matching funds. In our statute, grantees can only use those funds to go towards loan repayment. There are no administrative, there's no administrative support in the program. And the funds can't be used to launch a recruitment initiative either. The funds can only be used to support those awards. The majority of our grantees receive the matching fund from the state. More and more of our grantees are partnering with the actual practice site to come up with the matching funds, because remember I said the matching funds have to come from a non-federal source. Again, and some of our grantees have been able to partner with community-based organizations to come up with the matching funds, but that represents a heavy lift, and some of our states really have difficulty in coming up with the funds. So I'm very thankful for the Office of Rural Health Policy for partnering with us to try to get the word out about SLRP. It's done some really, really good things in the state. And one of our goals in BCRS is to get the word out, talk to as many folks as possible that may have some ideas for their particular states in helping the grantees come up with the matching funds. So that being said, I just wanted to end and take any questions.
Is there any questions for Captain Willis-Marsh? Press star 2 to unmute your line.
I have a question.
Go ahead.
Can you hear me? You were talking about the flexibility that states have. Do they have any flexibility on determining the practice sites? I noticed you have listed the rural health clinics and critical access hospitals, but they would still have to be nonprofit and provide primary care and offer a discounted sliding fee scale?
Yes, that's right.
So there's no way to be flexible on that?
Well, one of the things that we have done with the cause is we allow at least our National Health Service Corps providers to practice in the outpatient clinic that's associated with the CAW. So when they report their practice hours, we allow so many of the hours to be done actually in the hospital and so many in the ambulatory care center or the outpatient clinic.
Even if they are still owned by the for-profit CAW?
Right. Well, that we've come across this issue before, and we handle it on a case-by-case basis because we do realize that that is an issue. We have found that for some hospitals they have a nonprofit arm, and so typically we gather all of that information, and we have to meet with our Office of General Counsel to determine whether or not it meets the guidelines. So it really is determined on a case-by-case basis.
Thank you.
Well, thank you so much for joining us today. Captain Willis-Marsh provided her email address on the first slide, so feel free to follow up with her with an email if you have additional questions. And I think this is a great basic slide set to share with the providers in your state, so feel free to distribute that as well. It's a good overview of the expansion of the program and kind of what needs to happen within it. So thank you very much for joining us today.
Thank you so much, Nicole. We really appreciate it.
And at this time, I'd like to welcome Mark Holmes from the University of North Carolina at Chapel Hill, who's a member of the Flex Monitoring team, who's going to provide us with a brief update of what they've been working on lately.
Hi, thank you. So we have a really quick update, really only 3 points that I wrote down, but it appears I've lost it, so I'll see if I can remember it. The first is the Flex Monitoring team is redoing its website, and that should be launching very shortly to try and make it a little more intuitive and easier to access the resources for which we're looking, and that's in response to a lot of comments from y'all primarily, but others who have said it's harder to find things there. And so that we're hoping that should go live within the next month or two, so be on the lookout for that. The second thing that I wanted to just mention briefly is we, as a Flex Monitoring team, well, first of all, thank you to all of you who have helped distribute the Critical Access Hospital financial indicator reports, not only that you've used, but also your member or your hospitals and CAWs in the community. It's been another successful year with that, and again, we appreciate your help, and specifically TASC help with distributing those. For the next year, we're going to be adding and augmenting additional measures, and this is a major undertaking for the FMT. We're going to be adding in quality data as well as some community data to try to round out that report and make it dimensional across not just finance but also quality and community benefit and community resources, I guess, more accurately. So that'll be coming. We'll be probably sending out some straw men, if you will, to look for reactions. I know some people have been brought in by members of the MT to sort of get reactions on what measures belong and whatnot. And this will definitely be a prototype year, but we'll be very interested in your feedback and what would be most helpful for that. The timeline for that will probably be a rollout this summer. That's what we're shooting for in terms of getting those out. And the third comment is really less related to FMT, but just something that we wanted to mention. The North Carolina Rural Health Research Program put out 3 briefs at the end of November, or mid-November, I guess, on critical access hospitals primarily. One that looked at financial distress of critical access hospitals and what would happen to that distress level under various policy proposals. Another that looked at the effect on beneficiaries and access to care if a number of CAHs were to close. And then a third that looked at costs for rural and urban beneficiaries. To try and provide some data that would be useful as there's the ongoing debates about critical access hospitals, and there's a fair amount of misunderstanding out there. If you haven't checked those out, those may be useful to you. We've got some in my opinion, pretty good data on that help sort of provide a more full context than some reports have provided. And those are available on the SHEP Center's website at shepcenter.unc.edu. That's all the context we have. Any other questions would be great.
Are there any questions for Mark?
Mark?
Sure.
I'm not sure if as part of your community benefit reports it would be possible to include the charity and or uncompensated care expenses per hospital that are on the IRS reports?
Yeah, that's one of the things we're looking at to include, and so I think that's a great idea. I think that's a real important measure.
Any other questions? Okay, well, thanks for joining us today, Mark. I know that a lot of the staff here at the center looked at those reports that North Carolina put out, and those were really excellent. So I think what we'll do maybe is include the link to those reports maybe in the email recording message that we'll send out to the group, just to make sure everybody can access those because they're really excellent. So thank you so much. And so now I think moving along in the agenda, I'd like to welcome Tom Morris to the webinar. Tom is the Associate Administrator for Rural Health Policy at the Health Resources and Services Administration, or HRSA, and he oversees the administrative and policy activities of the Federal Office of Rural Health Policy. And they operate on a $138 million fiscal year 2013 budget. And that agency uses $1.8 billion annual budget for fiscal year 13 to expand access to quality health care through an array of grants to state and local governments, many of which you all are working on organizing not only the federal, the FLEX grant, but also lots of you work on SOAR and SHIP and other grant opportunities that come through ORHP as well. Tom coordinates ORHP's response to policy issues, and particularly the impact of Medicare and Medicaid regulations, which I know he'll be discussing with us today. He began working with the federal government in 1996 and joined ORHP in 1998. And so Tom today is going to be talking to us about some of the auditing and analysis functions that happen at various offices within the federal government. He'll be talking about and clarifying some of the issues that are impacting critical access hospitals with relationship to the Affordable Care Act, and also talking about a history of the critical access hospital program, kind of where it's been and how it's evolved today, and why that really matters. So I'd like to welcome Tom to the call and turn things over to him.
Great, thanks, Tracy. Can folks hear me okay? I'm assuming. You'll let me know if you can't.
We can hear you good.
Great. I think there's been a growing focus on critical access hospitals, both in the media and then politically from Washington, D.C. based folks, as well as we've seen some research studies by people who normally didn't have much interest in rural, suddenly decided they wanted to write journal articles on CHs. And, there's always a chance for misinformation, when different entities focus on things that we focus on every day. And sometimes things get lost a little bit in translation. And we're seeing folks across the spectrum sort of connect events that are not necessarily related, and sometimes they don't necessarily provide the full context on CHs, and in other cases we've seen, what some folks would perceive as misperceptions about CHs. And I think that puts both our office, but also the Flex coordinators and TASC, I think it puts all of us in a tough spot. There's a lot of noise out there of late, and sometimes it may prompt a press inquiry, or a state legislator might call you. You might get it from the Secretary of Health or from your governor's office. Maybe it's a payer asking about what a CH can do and can't do. And, given the fact that you're often the person they call at the state level, we thought that given all the attention that there's been of late, that we might talk a little bit about it so we'd all have sort of a common context for some of these folks and what they're doing, and then also how we might respond in a more coordinated fashion. And so, the reason I thought this was important to bring up is because once there's been a misstatement or an inaccuracy or a confusing point out in the public domain, it often takes on a life of its own. And so I guess this is really a plea that we need your help in making as much of this a fact-based discussion as possible. And I'll just give you a couple of examples. We recently had a press call that went to the Flex monitoring team, and it sort of intimated that rural hospitals are closing because of the Affordable Care Act. Well, there's nothing really CH-specific per se in the Affordable Care Act, so we weren't quite sure what was driving that. We've had other inquiries that conflated a combination of research findings. The recent research findings from a JAMA article, the Inspector General's report on necessary providers, and then a number of the regulatory changes that Aaron was just talking about, and brought that all together as if there was a perceived war on critical access hospitals and what the government was going to do about it. And it's very hard to sort of sort through those things when you're mixing apples and oranges like that. So, given that we have a number of new faces in the Flex in the state Flex coordinator positions, it made sense for us to have a call to try to set a common context in which we could view this. We deal with it on almost an everyday basis here at ORHP because of our role of advising the department on rural policy issues, but also through the work we do with research and with the Flex and the SHIP programs. But the reality is that when you work here in the Washington area, the message can come from DC or it can come from Baltimore with CMS, and it can get to the field, and then it can get distorted and confused. And the reality is it often ends up in your laps with people taking sort of shreds of the facts and sort of asking you a question that's hard to even get at what they're trying to understand. And this is all because of this new focus on critical access hospitals. Now, they've long been sort of an object of curiosity by policy wonks, by budget cutters, by a number of folks, and I think a lot of it is because they look different than every other facility out there. The cost-based reimbursement, for whatever, seems to be almost an abstraction with folks. They can't quite get beyond the fact that there's a class of facilities out there that aren't paid like everybody else. And you see it manifest itself in things like the JAMA article last year that looked at quality and outcomes in CHs and made a number of recommendations. But that's just one example of a number of people who are dealing with CH issues that may not have the full context of what we're dealing with here. And I think when you don't have the full context, or you don't use the full context to explain what your findings are, you can create a lot of confusion. And in some cases, there's some unintentional bias, perhaps, that is brought to bear. I'm not saying the JAMA article had that, but you can see the potential for it, especially when all you've looked at in all your career is, large academic health centers or large hospitals. When you're suddenly dealing with CHs, it's a very different thing, and some of the assumptions you brought into your earlier research may not have as much bearing for the larger research. And this is true not just for folks writing journal articles, but it's also true for some of the policy wonks that work at some of the oversight bodies here in Washington. And I'm talking about groups like the Medicare Payment Advisory Commission, the Office of the Inspector General, and the General Accountability Office. And those are the three that I'd like to talk a little bit about today. And you've got a slide, I think, that sort of goes through. So the Office of Inspector General is the first one. And most times when you say OIG, people quake in their boots and figure they're going to get arrested. And for the most part, there's some truth to that. If the OIG calls, you are often dealing with a Medicare fraud issue. But there's a whole two other sides of OIG that have nothing to do with that sort of law enforcement side. And they deal more with looking at evaluation and auditing of programs across HHS. And they typically do a couple hundred of these a year. And for whatever reason, the last couple of years, the OIG has included some provisions looking at critical access hospitals. And many of you may have seen their recent study. I'm sorry, we've got a little thing going on outside the office. Okay, it's passed. Anyway, the OIG was looking at this necessary provider issue and basically wrote a report about the way they'd sort of like the CH program to be if they could change the law, although it wasn't quite presented in that way. It was more done as a, several hundred CHs are not meeting the statutory requirements. And we know that they have a study coming down the pike on swing beds, and they're doing some other analysis of CHs in addition to that. What's important to know is that the OIG, while nominally in the Department of Health and Human Services, really is not under the Department of Health and Human Services. It really is an independent entity altogether. It decides the topic it focuses on. It writes the products. It does not clear them with anybody, and it puts them out in the public domain. So nobody at HHS can tell the OIG, that they need to correct something in a report. There's a chance to offer comments informally, but they don't have to take them. And so you need to understand that when you see an OIG report, that's not necessarily the HHS leadership saying this is a concern. It's the Office of the Inspector General saying it's a concern. MedPAC, probably you're more familiar with. Well, I'll start with GAO. GAO is an independent entity that is charged by the Congress with investigating certain things. And they've become much more active over the last couple of years in terms of their oversight of all of government. And they've been focusing on a lot of stuff at HHS. But so far, they have not done anything on critical access hospitals, although they have in the past done things on rural health clinics and some other rural issues. But they also are independent and reach their own findings. They will typically share those findings with the affected government entity that administers the program. But again, they don't have to necessarily take the comments that are submitted. And then the final one is the Medicare Payment Advisory Commission. This is the one you're probably most familiar with. It's charged with advising the Congress on Medicare payment policy. And over the years, they've looked at rural issues a number of times. They did a rural report about 2 years ago, and a couple of years before that had a number of rural points of analysis. And typically, in any report they do annually, there'll be at least some mention of rural issues in it. But again, they report directly to the Congress and are completely separate and independent from any other entity. And that's the point I guess I wanted to make. With the three of these are not folks that typically look at the CH issues, but they may wade in with them every now and then. Of the three of them, MedPAC is the most likely and probably has the most experience doing it. But GAO and the IG, these are not areas they normally deal with. And even if they do deal with them, they operate both Washington offices and then field offices. And even if you have one group that did a CH study 1 year, if they do another CH study, it might be handled out of a completely different office the following year, whether it's IG or the GAO, which means that you're not necessarily dealing with somebody who has past experience working on those issues. And again, context is so important in these things, and I'll talk a little bit about that in a minute. So then the other focus of CH is obviously the Congress, and sometimes they create some challenges for us because of the way they reference CHs and hospitals in the Medicare statute. CHs are sort of in this no man's land where they're not quite full hospital in the same sense of the PPS hospitals with all the regulatory framework that surrounds them, and yet they're obviously a lot more than a clinic or an ambulatory surgical center or a skilled nursing facility. And so they're referenced in several different places in the law, and sometimes Congress remembers that, and sometimes Congress doesn't. And depending on whether you're in Section 1886 of the Medicare Social Security Act reference, or you could be in 1861, which references hospital payment. Sometimes that encompasses CHs, and sometimes it doesn't. The only place that CHs are specifically mentioned is Section 1820 of the Social Security Act. And so unless Congress does 1886D hospitals and CHs, sometimes the thing they're trying to reference only affects PPF hospitals, and they're sort of left in limbo about whether it applies to CHs. And as a result, more confusion can sometimes happen. The rest of the material I'm going to talk about doesn't have any slides associated with it, so I'm just going to hit a number of points. Again, I mentioned context a couple of times, and I think context really does matter, because what I found sometimes when people don't have a lot of experience dealing with CHs is they fail to put the context in that explains why we have CHs in the first place and what's unique about them. And those are critically important in understanding why a policy is a certain way. And so I think, especially for the newer folks, I'd like to just talk a little bit about some of that history and context, because I think it's important for you to have, if you do get a call from the media or you do get a call from one of your state policymakers, whether it's the legislative branch or your governor's office or your health department. CHs came into being in the Balanced Budget Act in 1997. That was based on lessons learned from two prior demonstrations looking at what they called limited service hospitals. But it was basically, they were trying to figure out a way that Medicare could pay for hospital services in small communities in a way that wouldn't put them at financial risk. And what they learned was that under prospective payment system, because it's a system based on averages, it was very hard for very low volume hospitals to be financially viable in a sort of an administered pricing situation. And so the purpose of the CH was basically to ensure access for inpatient, outpatient, and emergency care for Medicare beneficiaries who live in rural areas. And they gave a number of tools to do that. One was obviously the cost-based reimbursement for Medicare services on the inpatient and the outpatient side. There's also a 96-hour average length of stay limitation. They allowed them to have swing beds and set a separate methodology for how those were paid. There were some exceptions to the regular conditions of participation that were done to take into account that we're operating on a smaller scale than a regular PPS hospital. If you met certain mileage requirements, you could own and operate a cost-based ambulance service. You could also elect to do the Method 2 billing, which allowed you to bill at 115% of the Medicare physician fee schedule for the providers under your employ. And then a couple years after 97, they were able to add in expanded lab reimbursement for CAHs. So what does all that mean? Well, it means a lot of things. What I would say is that, the creation of the CH was probably one of the most successful public policy products in the last 30 years, because it identified a problem, it tested it out in prior demos, it took the best lessons learned, and it right-sized the way we pay for and regulate hospitals in a way that allowed them to survive financially and therefore make sure they have access. So what does it actually mean? Cost-based reimbursement is sometimes misperceived. It doesn't mean anything other than for the Medicare patients, they get paid on their costs. Now, not everybody gets 100% Medicare patients. They sometimes have private pay, they sometimes have Medicaid, and cost-based reimbursement doesn't apply to either of those. And so it only accounts for your Medicare portion of your costs. Again, the focus was on ensuring access, and it was basically a financial and regulatory intervention to ensure that access. And then sometimes those changes get referred to as a subsidy, especially the cost-based reimbursement. But again, I think it's important to make people realize that it's not a subsidy. It never was intended to be a subsidy. It's basically a different way to pay for services and to organize those services in a way that's within context of the low volume and the small scale and the isolation in which they operate. And those are all important points to make, I think, anytime you're trying to explain CHs to somebody. And they're often the things that are missing from studies done by people who don't normally focus on CH issues. Initially, there were mileage requirements for how far a CH had to be, although there wasn't a necessary provider option that allowed a governor to designate a hospital as CH eligible, even if it didn't meet those mileage requirements, although that went away in 2006. But essentially, all of the hospitals that were necessary providers who didn't meet the mileage requirement were grandfathered in. And I mentioned that because that was a point that was ostensibly missed in the Inspector General's report. It was hinted at, but it was never specifically said that it would require a change in the law, and you'd have to do away with a provision of the law, that grandfathering in essence, in order to say that, you know, the 700 or so hospitals didn't meet the mileage requirements. Again, this is why context is important. Now, I'd offer a couple of clarifying issues, and that is, you know, there's always going to be policy issues with CHs. Just like Aaron went through all the ones he just talked about, that happens every year because, you know, Medicare payment policy is very complicated, and it's sort of like pulling a thread. You pull it, and it has all these connections to other things, and because CHs are in this no man's land, where they're not a PPS hospital, but they're more than some of the non-hospital providers, we're often trying to make sure they align with all of the provisions of hospitals. But because of drafting errors and other, I don't know, I guess inconsistencies in the regulatory framework, there are things typically on a year-to-year basis that need to get addressed and often are through the payment updates that Aaron just went through earlier today. And so often, a lot of times, things get lumped together that are both, sometimes they're legislative CH issues, sometimes they're regulatory CH issues, sometimes they're related to proposed legislation, and it's hard for people to sort all that out. And we've seen an increase lately in people sort of merging what is a legislative issue with a regulatory issue with what is a proposed issue. So let's go through a couple of examples, regulatory examples. Aaron talked about the 2 midnight policy. We talked about outpatient therapy service supervision, ICD-10. Those are all regulatory issues that the department can deal with and make regulatory determinations on. Bad debt would be another one, okay? But then there's proposed policy changes. And those are things that sometimes you see in research reports or in some of the reports done by either MedPAC or OIG or the GAO. And it's important to know when something is a regulatory issue and when it's a proposed legislative change. And so any change to, say, location standards like necessary provider would require a change in the law, and it's an important point to make. Similarly, if we wanted to change, if people wanted to see swing beds paid for more similarly to how we pay for skilled nursing services, that would take a change in the law. And again, it's an important point whenever anybody asks you about these things to find out exactly what they're talking about and which area they're in. Then there's other proposals, such as what the Congressional Budget Office put out a couple of years ago, looking at ways to save money in terms of deficit reduction. And one of the proposals they had was to do away with all the special hospital designations, critical access, sole community, Medicare dependent. Again, that was never even a legislative proposal. It was just identified as a cost saver by the Congressional Budget Office. Then you have things that are proposed either in bills or in the President's budget. And there you saw things like the 10-mile or less CHs would lose their designation, or they drop from 101% to 100. Again, those were proposals and not specific regulatory changes. In fact, the administration's budget proposal, which had the 10-mile thing in it, it would have required Congress for the first time ever to take the President's budget and actually implement it. And if there's one thing you can know from following Washington is that in true bipartisan fashion, every president's budget is usually dead upon arrival. It's more of a policy statement by the administration than it is any expectation that it's going to get enacted into law. Now, with the Affordable Care Act, it's such a big bill, and it touches so many aspects of the healthcare system that it's easy to sort of conflate what's going on with the ACA implementation and say that it's having some impact on CAHs directly, when in fact it's more of an indirect relationship. And so I mentioned earlier that somebody had asked, a media person had asked a question about CAHs closing because of the Affordable Care Act. Well, I think there is a reality that we may see a payer mix change for CAHs as a result of the Affordable Care Act, as more people become insured and we see reductions in the number of uninsured and bad debt or charity care. Now, this is going to play out differently in states that took the Medicaid expansion versus states that didn't take the Medicaid expansion. And so, it's very important to sort of draw those distinctions. There's a lot of work going on around quality in the Affordable Care Act, but none of those things apply to critical access hospitals. Another way the ACA may play out for CHs is what happens in terms of provider networks under the marketplace plans and how they set up which hospitals are part of their networks. But again, that's a plan decision, not a legislative or an HHS decision. So I guess in conclusion, what I'd say is context really does matter, and I think all of us have a responsibility to be a source of independent and verifiable information. It can help avoid future policy, and it can also help avoid confusion. So I guess what I'd like to ask is for your help in doing whatever we can to knock down misconceptions such as CAHs as boondoggles. You can check those North Carolina financial briefs that Tracy mentioned and Mark talked about, and you can see the realities of what we know about CH financial performance, and that is it's gotten better over time, and we used to be in the double-digit negative operating margin when the CH was first created. Now it's closer to zero. But again, there's still, even within that, there's still a lot of hospitals, CHs in particular, that are still struggling financially. The perception of CHs are low quality. Nothing in the data bears that out. It's a mixed picture. We have some CHs doing really well. We have others that are somewhat challenged on it. And we also know that not a lot of the measures for quality are relevant to CHs anyway. And that's what makes MB-QUIP so important, because it's the first rural relevant quality measurement program to be developed. And I think it's also important to look at policy proposals like the one that was in the administration's budget and understand what the impact would be. And if you've taken a look at the National Advisory Committee on Rural Health and Human Services brief on this, they looked at the specific impact of the 10-mile proposal and what that would mean in terms of number of CHs affected and also number of sole community hospitals affected. Again, verified by data that North Carolina ran for them. That allows you to have more of a fact-based discussion about the impact of the policy as opposed to speculation. And then I think the other thing that y'all can really help us with is helping people understand what cost-based reimbursement is and what it isn't. And you know, one of the things you can do is, if you don't know that, certainly Mark Holmes, George Pink, they can sort of put that in layman's terms that can help you explain it to others. If you get a complex financial question, you know, what I would say is focus on your state and don't generalize to others. And if you need help, contact Mark or George, and they can help you figure out how best to respond. You know, it's important, I think, also to focus always on access. You know, with the Flex program, we're focusing on CAHs and trying to make them as successful as they can be, but not because we want to save or protect every single rural hospital in this country. What we want to do is protect access. And so in your discussions, always keep the focus on access. And then I would think that, you know, as new reports come out, read them, know what they say, make sure you talk to folks in the Flex community, and then be ready to respond. Be ready to push back on things that are misperceived or push back on things that don't provide the proper context. And I think this sort of focus is not going away anytime soon, but I think if we all work together on this, we can help at least provide the context that will allow this discussion to at least be fact-based. And so I'll stop there if there are any questions.
Thank you so much, Tom. Does anyone have any questions for Tom? Hit *2 to unmute your line.
All right.
One thing I can think of, Tom, is, and you kind of mentioned this, and I guess I'd be asking you to speculate a little bit, but you know, we've heard and are anticipating that OIG is going to release a report sometime soon about swing beds. Can you explain a little bit for those that might be kind of newer to the program what some of the issues are regarding swing beds that they might be targeting?
Yeah, I mean, I think they're looking at an issue that MedPAC raised a couple of years ago, and basically, if you look at, well, let me step back. You know, the Washington, D.C. sort of policy focus tends to be always trying to figure out, are we paying the right thing for the right service? And so if you look at it very simply, you know, swing beds provide skilled nursing care. And we also pay for skilled nursing care through the Skilled Nursing Facility Prospective Payment System. And MedPAC noted that if you look at what we pay for the average SNF service, it's a lot less than what we pay for the average swing bed service, okay? And my guess is that the OIG is going to zero in on that, just like MedPAC did. And I think you can talk to any hospital administrator and realize that there's a little more to it than that. And some of it's tied up in the way cost-based reimbursement is done and the way those costs are calculated. But there's also maybe some difference in terms of severity of swing bed patients relative to the severity or acuity of SNF patients. And then the other reality is that there are towns where, I know Montana, for example, where you don't have SNFs in a lot of places. You only have the swing beds to provide that skilled care. And so, that's where I think the focus will be. And I think the challenge will be, if it does focus solely on the cost differential, how to tell the story of why swing beds were created. And it goes back, actually, I think, to the Each Peach and the math demos, which was, it was an effort to try to recognize that flexibility is the key in a rural community, and you don't have a lot of different providers. And so if you've got capacity to take care of a patient, why would you transfer them from one facility to the other when you could just sort of change the level of care within the same facility and make it easier for the patient and coordinate care better? Those are the sort of nuances that are often lost when we're dealing just with the numbers.
Great, thank you.
This is Terry Hill, and I just want to, I think what Tom is indicating here is absolutely right on. We think there's a lot of panic out there, unnecessary panic in that regard. That the urgency is obviously there, but panic is not something that we either need to be encouraging with our hospitals, or I don't think it's based in any sort of fact as well. This program has gone through its ups and downs. I've been involved with it, as most of you know, from the very beginning. And I do think it's extremely important to remember most of you probably weren't around at that time, but, we had hundreds of hospitals closing in the United States in the 1990s. So this program has really provided that means of preserving access in our rural communities. So we're preaching to the choir here, but again, I really endorse that idea of always coming back around to, it's not really about the hospital here, folks. It's about those rural communities and kind of maintaining that access as well. And then a comment about the Affordable Care Act as well. The Affordable Care Act, at least to my knowledge, has not put anything out there that's had a specific detrimental effect upon the hospitals. In fact, unfortunately, the expansion of Medicaid, the implementation of the insurance exchanges, et cetera, which would have had a disproportionately large impact on rural rather than urban, has sometimes been delayed in many of the states. But that, too, is not the cause of the problems we're experiencing right now. In many ways, it's because of the increasing complexities of healthcare. The financial problems experienced by a lot of our hospitals predate the Affordable Care Act, and I think basically there could be some indirect influence here, but the bigger question is going to be, how are we going to help our hospitals adapt to a value-based payment system? And I think most of you know that the Affordable Care Act didn't necessarily create this value-based system. The industry is moving in that direction. It is not going to come back. The hundreds of millions of dollars already invested in that model is going to require our critical access hospitals to have some sort of a role. And we just need to make sure that we keep them around long enough to know exactly what that role is going to be. But, personally, I'm very optimistic that on the back end of these changes, we're going to see, better healthcare systems where the hospital is going to play a really key role from a community health standpoint, access standpoint, et cetera. So I just wanted to throw my own personal endorsement and support for what Tom's been saying here as well. Thanks.
This is Pat Scow, and Tom, thanks for your comments, and Terry, you certainly hit the nail on the head there, but I just wanted to add, from the Office of Rural Health Policy's perspective, are you able to share information in a proactive way besides our research papers? Do they allow you to provide a report on the state of primary care in rural America or anything like that? Or, it seems like we mostly just get these reactive reports, and I know the research committee does, but they're periodically different types of programs. But do they reach congressional staff and people in key positions that look at policy?
That's a good question. I mean, within the GAO-IG sort of process, if we've gotten on the IG's, radar, and whereas in the past they would only ask to talk to CMS when they would take these projects on, they now realize that, because of our statutory charge within the
There's
department,
a different side.
part of it. So we do talk to them on the front end, but it's sort of a one-sided conversation, quite honestly. And but I will give them credit. They've allowed us to share additional research findings that they weren't aware of. One could say that's great. Another one might say, why weren't they aware of it? That's a different question altogether. Now, in terms of the congressional folks, we tend not to do, like mail our stuff to them. But, in this hyper-connected world, it's pretty easy to find. And that was one of the reasons we created the Rural Research Gateway, was to have a one-stop shopping for it all together. And I'm not saying this happened in any of these cases, but there are folks out there sometimes who do research where they sort of cherry pick what they want to get to the conclusion that they've already determined. That's something that's hard to work against. But to date, most of the folks we've talked to have been open to at least looking at the extra material we're willing to send them.
Okay. I know that in some states, periodically they do a report on particular, rural health or different areas of healthcare or resources or services, and I just didn't know if Congress ever does that, or it goes to a certain committee like Ways and Means or Senate on the Senate side that gives you an opportunity to share what you've got going on through ORHP and HRSA.
There's not. Those tend to be statutorily driven. Like right now, we have to do the department, I mean, not us, but they do a national quality report and they do a national disparities report.
Okay.
And there are often rural-urban cuts within that, although limited. But they do that because they're required to by the law, and so it's usually not done unless it's required.
Thanks.
Tom?
Yeah.
This is Kevin Dreesen in Arizona, and I have a question, and that is when the OIG report came out this summer that really looked at the distance issue between hospitals, we got a lot of comments from some of our rural hospitals that that in fact when states that have a lot of critical access hospitals and where there's a saturation, some of our rural hospitals express the stereotype or the belief that there might be sort of an artificially holding up some of those hospitals because of the CAUD designation for hospitals that are really close to one another. And have you looked at that, or have you seen any effect of distance as having, short distance as having a negative effect on the hospitals?
No, I don't know if Mark Holmes is still on, but if he is, I'll let him jump in after this. But one of the things that came out in the MedPAC report was sort of not in the report so much, but it was sort of hinted at in the public meetings where they discussed the issue, and it was sort of this sort of hypothesis that if you had two CHs near each other, like say 8 miles from each other, that one would be economically viable and the other one would be struggling. And what I think, if I'm not mischaracterizing it, but I think what North Carolina found when it did the work for the National Advisory Committee was that, in fact, most of the CHs near other CHs, they all tend to be doing pretty well financially. Their volumes are pretty good. Their financials are pretty good. The real correlation, and I think this is also borne out in the 3 briefs that Mark mentioned earlier, it's the ones the further you go out. The further you go out the mileage spectrum is where you really see the financials sort of fall. And so, and that's why in our analysis, when we looked at the 10-mile proposal, it's kind of hard to get too up in arms about it because, by and large, those hospitals are doing pretty well.
Yeah, this is Mark and George. I grabbed George and brought him in about 30 minutes ago as well, and we Tom characterized the findings perfectly. So, nothing to add.
Any other questions at all for Tom?
Yeah, Tom, this is Kenny in South Dakota. When OIG was developing that report, they contacted me because they had some questions on some of our hospitals, and I just shot a thing out just through NOSOR to some of the other states just to see if anybody else was being contacted. Do you want us to contact your office if an agency like that is contacting us? I don't remember if I did at that time.
I think it's always great to let folks know. We'd certainly want to know, but I imagine that Tracy and Terry and the TASC folks would want to know. I think that the UNC folks would probably be interested. I think that, and then your colleagues. Again, my whole purpose in sort of commandeering portion of your agenda was just to make sure that we could begin sharing information in a way that allow us to at least have a common context, and part of that context is knowing how to respond when you get an inquiry from these folks. I don't think anybody's out to get CHs. I think it's when we see things that that we sort of wince at in terms of how they're referenced or things like that, or it's more out of a lack of perhaps the full understanding of things. And so the more we can do to share the research findings, to talk among each other and figure out the best way to explain the program, and then really insist that people include that context. I mean, I know I've become a broken record with the OIG to the point where we've even drafted language that says next time you include a provision that explains CH, please use these 3 paragraphs. Because again, it talks about actions. If you only talk about this in reimbursement terms, it's just a hard argument to recover from. And so I think the short answer, Kenny, is we'd love to know, but I think all of us would.
And Kenny, this is Mark. That was for the distance study you're talking about?
Yeah, yep. They basically sent me an Excel file, and they basically wanted to look at more of the rural definition part of it, though, of a hospital. So they had me sent me a specific Excel file I needed to complete, and then I, regarding a specific hospital, and then I provided our, one of the things that we can do is we can, for the rural definition, if we have a state definition of rural, we can use that. So that's what I did, was I sent them our state definition of rural, and, put it in that Excel file that they sent me, or a link to it, I guess.
Okay, thanks.
And that was,
yeah. Sorry, this is Tracy. I just wanted to offer that, or to anyone, that if there is, another round of inquiries from OID or another group, that maybe let TASC know first, and we can contact all the other groups instead of you having to do that. We can kind of act as the middleman and contact the monitoring team and OHP, et cetera. And I think that there's other partners as well that are certainly interested in all the issues that we're talking about today, and that includes NOSOR and NRHA. And so if you want to let us know, we can connect as the web of the network there and get the message out to those that should have a heads up as well. We'd be happy to do that.
Yeah, because I think I used the NOSOR listserv and just asked if anybody else had, and it happened probably about a year before the report came out, and at that time, I had no idea where the information was going to go or what was.
Right. Yep.
But also be prepared, if the IG does come down with something on swing beds, it might include some things that we're not going to like. This whole swing bed, if you're wondering where this is coming from, there's been strong protests from the long-term care industry in general that instead of sending patients to nursing homes and other long-term care facilities, we're keeping in hospitals, et cetera. So hopefully it's not going to be all that negative, but I wouldn't be real surprised if there weren't, when that finally comes out, that there might not be some things in there that we're going to have to be prepared for.
And thinking about preparation, I think Tom mentioned a lot of areas, and I think we'd be pretty remiss if we didn't offer some resources too for you that if you're looking for education about some things. So there are some resources that are available on the Flex or on the TASC website I just wanted to mention. If you're looking for an overview of the Flex program and its scope, if you go to the Flex Coordinator Manual, there's a document on that, or in your print Flex Coordinator Manual as well. If you're looking for something that summarizes the history of the Flex program, that's also in the Flex Coordinator Manual. There's a brief summary as well as all the legislation. If you really want to get nitty-gritty about each of the different changes that happened that Tom summarized with critical access hospital legislation, the Flex program, that's in the Coordinator Manual. We also have a slide set from ORHP that's a history of the Flex program as well that will make sure that the most up-to-date one is on the website too. Tom talked about quality and why that really matters in critical access hospitals, and so I encourage you to look at the resources about MBQIP because they really, I think, the federal office has done a really great job of explaining why that program is so important, not only to motivate critical access hospitals to participate in the program, but certainly is a good educational piece for those that might be interested as well. And there's the YouTube video, and then the annual report that comes out from the Flex monitoring team about the hospital compare measures always talks about why reporting quality measures and publicly reporting those measures is important as well. So great resources there on quality. About finances, Tom mentioned, reaching out to George and Mark, who are always extremely responsive and extremely knowledgeable about this. You can also, and you should, look at the annual Critical Access Hospital Financial Indicator Report for all the CHs in your state and take a review of that. And then if you're interested about just some of the basics about CH finances, there is a CH Finance 101 manual available on the TASC website that answers even some really basic questions like what is Medicare, what is Part A of Medicare, what is a swing bed, what is cost-based reimbursement, lays out the top 10 indicators for financials to review why they're important, what way they should be trending, and what the U.S. median is as well. And then regarding community, John Gale and Andy Coburn are great resources about that if you're looking for someone to talk with. And last summer, Cammie Norland of the center staff here, along with John, did a great presentation at the Flex conference about why community health really matters. And it gets kind of at that, I guess, a little bit of the softer side of the community